Chinese, they need a VPN for Zoom. So I just double check if their question and raise a hand, we can find out on the Zoom as well.
No problem. And if there is a problem, Wendy, you can copy and paste it here.
Okay.
And we can still answer it at the end, if that makes sense. So in case it doesn't work, you can copy paste it in this, and we will still answer it.
Right.
Who is doing a countdown, Manuel? If you are happy to, just so we are okay. I think it's about 1 minute on my time, but we can wait a little bit longer if you want.
You are going to be ready in 1 minute. Maybe you send me when you can send me the countdown, and I will start if you like.
Good luck, everyone. Not that you need it. You're all perfect. So.
Yeah. Okay.
I think it's time to start. Hello, everyone. We have already a large audience today for this webinar dedicated to suction devices and other technological advances in endourology. It's a real honor to welcome top international surgeons and researchers. We start with a lady eminent, Dr. Amelia Pietropaolo, based in the UK. Hello. Other big name of urology, Dr. Pablo Contreras from Aleman Hospital in Argentina. Hello, sir. From Swiss, excellent Dr. Etienne Keller will give us a presentation. And finally, I'm very proud to introduce a real sommelier, Professor Bhaskar Somani. Thank you to be here with us. Professor will give you the lead now.
Thank you so much, Manuel. Thank you to Cassia and of course to Wendy and to Team Pusen for organizing this for us and to allow us to share how suction has changed the role. So I'm going to just share my screen briefly. I think suction devices and technological advances are going to push the limits of RIRS. Whether we like it or not, it is here to stay. And I'm glad that Pusen with the in-scope suction has really made a big advance towards it. And is it a feature of endourology? I think it is. And this is an overview from the Ulysses section, which has just come online. I've got with me already introduced Dr. Etienne Keller, Amelia Pietropaolo, and Pablo Contreras, and we are going to share with you a glimpse of what holds in the future, but how we have progressed through time. This will be the
recording in progress.
So we will have a laser and settings, which is pre-recorded from Dr. Keller, first of all. Then we will have suction cystoscopes in endourology, and I know Pusen have got a new suction cystoscope, and hopefully we'll get a glimpse into that. And of course, smaller ureteroscopes are the future, and why not have can be small and also have suction. And I will share some cases that we have done and the excellent results we have achieved with that. In the interim, if you have any questions and answers, we'll be very happy to take them as we go along in the chat, but we'll run through the presentations. And if there's a recurrent theme, we'll answer some of your questions at the end. And also probably discuss within the panel what we think of it. So once again, thankful to Team Pusen for doing this. And I'm really looking forward to hearing the latest views from my panelists. Thank you. I'll stop sharing now and we will start Etienne's pre-recorded lecture, who couldn't be unfortunately with us today. Thank you. Wendy, over to you if you want to connect Etienne's presentation, please.
Okay, just give me a second.
Bhaskar for the introducing words, and also to Pusen for giving dear friends and colleagues a very warm welcome. And a big thank you to Bashka for the introducing words, and also to Pusen for giving me the opportunity to tell you some facts about lasers and laser settings. And thank you for joining in. I'm working with those companies, and I want to ask you first, which lasers are we talking about, in fact? So in ureteroscopy, nowadays, there are basically three different lasers you can use: the holmium-yak, the thulium fiber laser, and the so-called pulsed thulium-yak laser. All the lasers have been verified to be able to address all the human urinary stone types. We just published that recently, that the newest in the block, the pulsed thulium-yak, is also very capable of addressing the stones. And then the nice thing is that all the lasers are also very good to treat tissues. And this is a very personal perspective, but I think the best in the block here nowadays is still the thulium fiber laser if you need to combine it with tissues. So talking about laser settings, we have to set some basic knowledge, some definitions. Here is the axis of time, and you know that all those three lasers, they are so-called pulsed lasers. It means that the photons are not going out of the laser all the time, but only in very short pulses. The pulse is defined by a certain peak power, and the peak power is multiplied by a certain time, which gives you, in the end, the pulse energy. This is how much photons come out at each pulse. And then it's a matter of how many times you repeat that over time, which is defined by the frequency, to result in this calculation of the pulse energy times the frequency, which gives you the average power. So just as an example, if you multiply the frequency by 2, of course, the average power is multiplied by 2. And why this is important? It's because the lasers are good and efficacious, but they are also dangerous. And the main hazard is that you will use too much power, too much joules per unit of time. I've stopped at some point collecting all the papers that address the topic of the danger of intrarenal temperature related to lasers. But basically, I think there are some very important statements that must be made here. It does not depend on the laser type. So it really depends on how much is your average power, because this will then define how much the temperature within the kidney will rise. It is linked to the physics rules of the conservation of the energy. A statement in this very nice review that I want to question is that the authors think that whatever you use as settings that are below 40 watts are safe. This is not exactly what we would get. If you go back at the literature, most of the studies, they will show you that if you use a flexible ureteroscope with, let's say, 10 milliliter of irrigation per minute at room temperature, then it becomes dangerous if you go beyond 25 watt. Believe me, this is what is out there. So at some point we made this little editorial and we said, you know what, for stone applications, for ureteroscopy, you don't need a high power laser, really not. And I just want to explain you where does this nomenclature come from, low and high power laser. It's something that is in fact historical. You have to go back to the architectural construct of the holmium-yak. It's a laser unit which by its construct design gets very, very hot. And this is why one holmium-yak laser unit cannot go beyond 30 watt and about 30 hertz. This is the reality. So when there was the need for more power, the industry, they just put together and synchronized several laser cavities of a holmium-yak, and this in the end became the high power generator. So now you know, to answer this question, the differentiation between a low and a high power laser is very artificial and is historical and is about at 30 watts. The need for a high power laser in the history of urology was not related to ureteroscopy. It was Peter Gilling from Australia who was developing the laser enucleation of the prostate. That was back in the 90s. And it's only later that some urologists saw that the higher frequency range of those high power lasers will be interesting for dusting, but it's not really the the high power. It's really just the frequency. So let's put the two lasers next to each other. I think that in terms of pulse energy, both lasers, they do very good. We want a low peak power, we want a low pulse energy, and a long pulse duration. The difference probably is the frequency, although here I want to highlight later the problem of the visibility that comes with high frequency. And then both lasers should operate at low average power, as I have already mentioned, because of the temperature. So the topic of the high frequency and the visibility, I like these two videos because they show the problem and the reality. On the left side, you have a urologist that operates with a decent frequency and the visibility is constantly good, which means that he or she can stay on the laser pedal. On the right side, we have a much too high frequency setting and the visibility gets very bad, so it becomes dangerous. The laser might go on the mucosa and you constantly have to stop and go. This is the big difference. And I really think that there is no advantage if you always have to stop to have a high power laser. This is just a figure, you know, the low power Mini Cooper will arrive at the same destination exactly at the same time if the Mini Cooper can just constantly laser compared to the Ferrari, which has to do the stop and go. And in fact, this stop and go, this intermittent laser activation is a concept that I really don't understand. Some authors will say this is good for maintaining acceptable temperatures. This idea, in fact, it comes from the US. There is this publication from William Roberts, who shows that if you activate the laser only 50% of the time, it allows for the fluid to cool down. But it's a very strange concept, isn't it? Why would you not find a good laser setting with good visibility, and then you also don't have the risk of the temperature? In fact, the Americans themselves, they showed these very interesting results, which are that at high frequency, the risk is that starting from pulse 5, there is no effect on the stone anymore because all the stone has been ablated already. So you're just shooting in water unless you begin to move the fiber a bit. So the high frequency range, and this is proven in vitro, is limited in the efficacy. At some point, you're just cooking water. To illustrate these concepts, the group of Olivier Traxler has made this nice publication which compares the low power with the high power laser, and you can see that for the high power laser you need a lot more joule per millimeter cube, so a much worse efficacy, a very high energy consumption per volume. So, some days ago we published this little editorial. Again, this is a review of the literature, how much joule per millimeter cube of stone are published out there, and you can really see that the high power lasers and even the pulse modulated lasers are not the ones performing the best. They have a very high energy consumption. So last but not least, there is a bit of solid evidence also to underline that the low power is equivalent for stone application with the ureteroscopy compared to high power lasers. So I will definitely say for ureteroscopy, you don't need a low power laser, okay? You can have a decent frequency, you will stay at the low power, and the low power laser is even cheaper. So that was nice. I just now gave you some concepts, but I think we need to detail the topic a bit further because you still don't really have any good laser settings yet. First of all, I want to question with new technologies such as the intrascope suction, will this be the solution? Will this maybe completely alleviate the risks of the temperature? Well, I don't think so, not for this purpose, because I come back to this publication from William Roberts. You can see that at 40 watts, within less than 10 seconds, the irrigation fluid in the kidney model was rising 20 degrees. So it's too much. So even with the suctioning scope and you do intermittent suction, I think there is still the hazard of the temperature with the laser. So which laser settings should you really choose? Let me remind you that there is not only the pulse energy and the frequency, there is also something called the pulse duration. And in fact, if you look from a historical point of view, the industry, together with the urologists, they were always aiming at a longer and longer pulse duration. The reason for that is that we want to do some stone dusting. The pulse modulation is something nice. It has less retropulsion. But clinically, at the time, any pulse modulated laser did not really show a huge difference compared to the conventional lasers. We recently published this little editorial. I think it's an important point of view. I think that there are some messages there in this editorial. First of all, with the Holmium-YAG laser, you will always want to set the pulse duration to a long pulse mode. There is only one exception. It's for the urologists that wants to fragment the stones. The Holmium-YAG is certainly the best to fragment. So with the long pulse duration, you have less retropulsion, you have finer stone dust and less risk of the fiber burn back. With the thulium fiber laser, you should always go for a short pulse because, as you just saw in the graph before, the short pulse of the thulium fiber laser is in fact a very long Holmium-YAG pulse duration equivalent, okay? We made one observation. This is not based on evidence, but on evidence. The thulium fiber laser seems to have a bit of problems to manage the lithotripsy of infectious stones, struvite, and also of the type cystine stones. And the last observation that we made in this editorial was that the new pulse thulium-YAG laser has a pulse duration which is exactly between the Holmium-YAG and the thulium fiber laser. So maybe this is a nice sweet spot, and maybe this will be one of the best lasers in the future, but we don't know yet. In fact, we don't know a lot. For example, we don't know exactly what are the mechanisms behind the laser lithotripsy. The thing that we know and we've learned with the years is that it's of advantage to have a stone dusting laser setting, so that at each pulse there are no fragments, but very, very fine stone particles. How fine should those particles be? We published that a couple of years ago. We think that the particles should be smaller than 250 micrometers. It's very, very thin. It's about half the diameter of your laser fiber, usually. There's this nice publication from Ralph Clement, who compared the Holmium-YAG with the thulium fiber laser and asked which is the better to make very fine dust and to clear the stones. It's the thulium fiber laser. It is even better than the pulse modulated Holmium-YAG. So now you asked me, this was very nice and this seems a bit theoretical. What about the real outcomes? What about stone-free rates? Well, there are two studies we must highlight. The first one is from Stephen Nakada from the US. It compares the Holmium-YAG with the thulium fiber laser in a prospective randomized controlled trial. It has a little bit a methodological problem because the power analysis defined by protocol that the difference between the groups will be 6 minutes. But the very strange thing is that when you go to the results, the laser time is barely 3 minutes. So where should we find a difference between the laser groups if the laser time is much, much shorter than the expected delta? So I think the study is a bit underpowered, but still there is a nice message. In this cohort, it was patients with rather small stones. You can see that by the operative time. The operative time was just 20 minutes. And the message of this study, despite the methodological limitations, is that both lasers are very good for patients with small stone volume. And this is in industrialized countries, it's the most frequent case. So the second study we should have a look at is the study from Norway. Here they compared patients with much larger stones. And this is where finally we could provide some evidence that the thulium fiber laser is much better than the Holmium-YAG. If you have a large stone burden, you have a much better stone clearance rate, shorter operative time, and less bleeding risk. I think methodologically, this is the best study out there. So if you ask me currently which between the Holmium-YAG and the thulium fiber laser is the winner, it's the thulium fiber laser. We need some data about the pulsed thulium-YAG, and this is not out there yet. We have to wait that. So again, where is the new technology coming at hand here. I think that the suction will be very important, not for the temperature topic, but for the efficacy to clear the stone dust. And in fact, from all those parameters that may impact on our stone guidelines, I think that the one parameter which we can still optimize more is the topic of the scopes. I think that with miniaturized scopes which are capable of suction, we will be able to tackle much larger stones if needed. So finally, is there a consensus about the laser settings? Well, you will be a bit disappointed. There is absolutely no consensus. This is data provided from the industry, and you can see that the box plots are very large. So the industry doesn't really guide you very well to choose your settings. The same is valid if you look at experts' opinions. There was this nice study looking at the Twitter posts, and you can see that the so-called experts in the field have very different opinions and laser settings. So this was the opportunity from my friend Theodoros Tokas to invite some of those experts and make a consensus paper. And I quite like the results, because if you look at the average power in the ureter, we all agree within experts that you should stay within a margin of less than 10 watts. In the kidney, you should stay within a margin of less than 30 or even 25 watts. This is an important message. And if you're not sure, whatever the laser you are using, I would recommend to start like this. This is probably the most important message of this presentation. You always start at putting your pulse energy at, let's say, 0.4 joule. It's a low pulse energy. And then for the Holmiak, you use a long pulse. For the thulium fiber laser, a short pulse. And you start with a very decent frequency of 5 Hertz. If you are satisfied with the effect, then you can increase the frequency. If you think that the pulse energy is not good yet, you can increase it a bit until the effect on the stone is good. But the frequency, please only increase it step by step. And if you see that the visibility gets impaired and you have to do intermittent lasering, then you go back to a lower frequency. And like this, you will certainly stay in an adequate low average power range. If you need some guidance, we tweeted those posts. This is my post on the thulium fiber laser. My friend Vincent de Coninck then later had his post for the Holmiak laser. They are free to download on Twitter. Take-home messages is stay with a low average power. You don't need a high power laser. I think that anybody who does intermittent laser activation has not reached ideal settings, and you shall adapt the settings for each patient. Again, thank you so much for engaging today. Please don't hesitate to contact me for any questions. And thank you again, Pusen, for making this possible. Bye-bye.
That was a wonderful presentation from Etienne. Some very nice messages. The debate between TFL and Homium, I probably would not fully agree, but that debate will go on. But now we will talk about the suction cystoscopes, which my colleague and friend Amelia would share. Amelia, over to you.
Thank you very much, Bhaskar, and thank you very much, Pusen, for this very nice opportunity. It's always nice to share knowledge and opinion in a good webinar. And I hope you can see my screen now. Yes, so this is our webinar today, and I'm going to talk to you about single-use suction flexible cystoscope, and within the, of course, very interesting topic of role of suction in endourology. And let's see if this is a game changer. So my name is Amelia Petropaula. I'm a consultant urological surgeon. I work in a university hospital, Southampton, and I'm part of the European Association of Urology, in particular in the ULIS board and the Young Academic Urologists. And I want to introduce to you the new flexible video cystoscope, which is this one that you can see here. And it is essentially, it's a flexible cystoscope, as you know, many of them, but there are many characteristics that are unique and new. For example, there is a built-in two-way tap that is included, and the working channel is straight. Then there is the unique capability is to suction and to control the suction thanks to this button that allows the operator to activate suction and evacuate fluid from the scope directly. So it's an in-suction scope, as we were discussing earlier. And of course, improvement of that is that it can improve the visibility and the control of the surgeon. So to be a flexible cystoscope, of course, needs to allow to visualize the whole bladder. And in particular, it does it thanks to a 210-degree up and down deflection, and which facilitate the retrograde views. And also it's got a dual light source that allows all parts of the bladder or the kidney to be visualized without any blind spots. So because of that, it's also being used, it can be used for PCNL and mini PCNL because it's compatible with the PCNL sheets and allowed to navigate the calyces for difficult spots where stones can be not reachable with a rigid nephroscope. And of course, being a flexible cystoscope allows efficiently to remove the stent, and also thanks to the reduced diameter is more tolerable to patients. And it's got an HD image processor that not only gives an amazing view of the images, but also allows you to record the videos or the still images, and this can be connected to your hospital system. And these are some of the numbers that you would want to know. Of course, this pixel resolution, which is very modern and excellent, allowing excellent view. But also the field of view is 90 degrees with a depth of field between 5 and 80 millimeters. And the diameter of the inserted portion is around 5 millimeters, and with a working length of 380 millimeters. But the working channel is 7.2 French, and in some areas even wider than that. So the irrigation and suction will be excellent thanks to the bigger working channel. And this is what I was mentioned before. This is the integrated suction button. So essentially with your index finger, while you're still manipulating your scope, you can press this button and a suction activation will start, and the suction and will go through this blue little tubing, which is connected to the tube that goes to your negative pressure device to allow suctioning in real time, so you can see much better and reduce the intrarenal pressure or the intravesical pressure in this case. So this is how the scope looks like, and the most innovative things are these two. So the suction valve, which activates the suction when pressed down, and as you can see is the number 2, and this is connected to a connector that is used to connect to a negative pressure device. So each of us has a negative pressure device in our theater that we use for our wastewater, and this can be connected to the same one. So for example, we have the Neptune that gets connected to this very easily. You also regulate the power of the negative pressure according to how much you need to prevent your bladder to collapse completely. So the indication for use of this flexible cystoscope can be, of course, the one of normal flexible cystoscope, so investigating cause of hematuria, of lower urinary tract symptoms, or diagnose bladder disease. But not only, you can also treat, of course, bladder disease thanks to the working channel that you can use to insert lasers or baskets or graspers and diagnose enlarged prostate. And thanks to the fact that this is connected to a very small portable screen, you can bring the scope wherever you want, like in emergency department or in the ward, to see patients that otherwise wouldn't be able to come to your cystoscopy suite. And because it's a single use, it allows a non-sterility, and it's got an increased visibility, as we said earlier. And because it's fully digital, you can connect, you can record everything and then transfer it to your hospital electronic medical records. And because, of course, it's always new, you can reduce the risk of contamination and infection, but also avoid expensive maintenance that are related to sterilization and reprocessing of normal reusable scopes. So how we can use it? We can use it either for diagnostic procedure, as we said, for bladder neck stricture, benign prostatic hyperplasia, bladder cancer, insertion or removal of stents, And also it's very interesting that if you can activate the suction button, you can also take cytology samples or send the urine for analysis thanks to the suction button directly from inside the scope, which allows to reduce your time of the procedure. For treatment, of course, you can use it for dilatation of lasering of urethral strictures, but also bladder tumors resection and diagnostic biopsies, or to remove or insert stent. For example, in our unit, we now insert stent with the flexible cystoscope under local anesthetic only. And this scope, thanks to the suction function, can allow you to see much better while you're doing it. But don't forget that you can also use it for PCNL. So for difficult stones that are not reachable with the rigid nephroscope, you can insert this flexible cystoscope and use it as a flexible nephroscope inside the kidney. And this is a short clip that will show you the characteristics of the scope with a bit of music in the background. So you can see this is the scope, how it looks like, the cystoscope, and this is the integrated suction valve that you can press with your index finger, and the irrigation tubing gets connected to this area of the scope. And you see the handle is new and is ergonomic, so that allows an incredible manipulation. And this is the deflection angle that will allow you to see all parts of the bladder. And this is the suction function. So you can see how your vision improves and you will have less pressure. And you can also insert it in the PCNL nephroscope sheath in order to be able to treat the stone and also reduce the pressure at the same time. And you could see that the working channel is 7.2, so allows the instruments to go through, remove the stent, but also the irrigation to be very good. And in our practice, of course, we need to see what are the indications to use these. So you can see that when you do diagnostic cystoscopy, sometimes you have a poor visibility due to infection or cloudy urine, or the urine can be full of debris, so the view is impaired, as you can see in this picture here on the right, and you can't see very well. So the suction device allows you to have a better visibility and to suction in real time in order to have crystal clear urine again, and to be able to see all parts of the bladder without any bias of debris or clots or anything that can impair your view. So this also fulfills the expectation of the getting right first time, or GIRFT, which is very, very important in the UK because it reduces the cancellation caused by the poor view. So you can be sure that when you do a cystoscopy, you can do it in the first time. You don't have to bring the patient back just because you don't see very well. At the same time, flexible cystoscopy can be cause of infection itself. And in the literature, this is described between 2 and 10%. And unfortunately, infection after flexible cystoscopy can also present like sepsis. So we need to be very careful in our patient selection. And we have seen in our hospital that there is a slight increase of infection after flexible cystoscopy, in particular in the last 2 years. So we've tried to see what are the risk factors related to this. And we found that most of these risk factors are related to indwelling catheters or enlarged prostate with bladder outflow obstruction or chronic retention. So all signs that in the cystoscopy you can see as cloudy urine, diverticular tuberculated bladder, and therefore all patients that will have a high post-void residual and therefore a high risk to have infection after instrumentation. And that's probably the patient where we will benefit most from the suction function to prevent them to have an infection or to be unwell after flexible cystoscopy. In terms of operative cystoscopy, you know that now we can not only diagnose cancer with flexible cystoscopy, but we can biopsy and treat tumors with little laser fibers like Tula or Thulium laser inside the bladder. And thanks to the suction function, of course, we can be able to continue the lasering of the tumor without the vision to be impaired. So you always have an improved vision thanks to the suction and the irrigation, but also the HD imaging allows us to see the tumor much better and to allow to remove it all in the first diagnostic procedure. And we wish we could have had a suction flexible cystoscope by Pusen the other day when we were doing a cystoscopy of our augmented or neobladder. So in these cases, you know, this bladder can be very large, full of urine, sometimes full of mucus or full of stones, just because they're made of part of bowels. So the mucus is very common. And if you don't have an active suctioning device, unfortunately, you will have an impaired vision, and sometimes you can miss tumors or stones while you're doing your investigation. So this the role of this scope in this specific type of bladders is new, and probably we should use it even more because it's very important. And of course, we have mentioned that we can use this in PCNL and in mini PCNL, where we would normally use a nephroscope. As you can see, some of the stones will be missed by the rigid nephroscope that has not the torque enough to navigate all the cavities. So the flexible nephroscopy, flexible nephroscope, and the use of this specific digital scope in the flexible nephroscopy will allow you to navigate all the calyces and remove stones in very remote places in the kidney where otherwise you wouldn't be able to reach with one tract or with one operation. So prevent you to bring the patient back or to have a procedure that will not allow you to have a complete stone-free rate. At the same time, the suction device will allow you to see better, avoid to miss stones, and improve the visibility. And in terms of visibility, I wanted to show you one of the videos that we've done. This was done actually with a flexible ureteroscope, which Pablo will have chance to explain much better than me later. But I wanted to show you how similar is the flexible ureteroscope to the cystoscope, and the ergonomic handle is the same and the button is absolutely the same. So while you press your button, you can allow the view to improve thanks to the suctioning function. And you can see that in this kidney, the stone is almost invisible due to the fact that there is a dense debris that is occupying the calyx, and the urine is very cloudy in the lower pole calyx. So thanks to the suctioning function, you can eliminate and suction all this cloudy urine in order to have an improved visibility and improved view, be able to see the stone, and also laser it under vision. So this is very important also as you laser it in order to remove the dust in real time. So the operation time is less. But more importantly, when you do a renal procedure, so either nephroscopy or ureteroscopy, you can reduce intrarenal pressure and can prevent that this infected urine will go in circle and cause sepsis post-operatively. So it is very important to use this suction function in these complex cases in patients who have high risk of sepsis, or that they will have large stones or the previous long standing infection previous to this operation. And to conclude, the indication for a flexible suction nephroscope, it could be to improve the drainage and of course improve visibility. Stones that are very difficult to reach with a rigid scope, you can reach it with the flexible scope, and you reduce the risk of sepsis thanks to reducing the intrarenal pressure. And you can have a better view during your laser lithotripsy thanks to the capability of aspirating the dust real time. So I thank you very much for your attention. I'm very happy to answer your question in the Q&A later.
Thank you so much, Emilia. I think you have probably convinced most people not to go and invest in suction cystoscopes, at least for some patients, if not for all patients. Very nice presentation. And with that, it's my pleasure to introduce Dr. Pablo Contreras. Everybody knows him. He's the endourology giant in South America. So Pablo, over to you.
Thank you, Oscar. Thank you very much for your kind invitation, and thank you, Pusen, to make it possible. It's a great honor for me to be here with Amelia and Etienne and with all the colleagues connected around the world. So I'm going to share my thoughts about smaller scopes. I live both eras in PERC, the standard era and the mini era. And now we learn very well that using smaller scope, we have less bleeding, more tubeless, and of course, less trauma. So what's happening in the ureter? The ureteral anatomy that we know today was described more than 500 years ago by this virgin anatomist, Andrea Vesaliu. And we know that we have a tiny tube. And as you can see in this video, the average of the diameter of the ureter is between 3 and 4 millimeters. and you can see all the curves and the strictures that you can find in the normal ureter. So the key is to adapt the scopes to the anatomy. We cannot adapt the anatomy to the scopes. So keep in mind this number, 3 millimeters. Why? I will tell you later. But let me show you a couple of cases that we treat in the last weeks. This is a patient, this is a male with 52 years old with hematuria. And you can see in the right renal pelvis, this stone, 9 millimeters. It doesn't like too hard. It's a soft stones, but look at the ureter. It's less than 3 millimeters, the proximal ureters. Look at this lady, 23 years old, with multiple small stones. We can discuss later if we need to treat it or not. But you can see many stones at both sides, the 3 or 4 millimeters. Not very hard, seems to be soft. But again, look at the proximal ureter. The diameter is less than 3 millimeters. Sometimes we decide to treat bilateral procedures. I don't know, and sometimes we don't know very well what's a stone, what is a renal Randall's plaque. So we need to take a look. And always, of course, it's easier to do it with a small scope. You can see at the right side, a Randall plaque and a stone at the left side that we could remove. So just a moment, let me advance. So there is some animal evidence that using smaller scope, we can decrease the degree of hypoxia in the urethral wall. And that could be important, most importantly in long procedures. Why? Well, because we are treating now more complex cases like this. Patients with big stones under Coumadin, or patients with anatomies, non-favorable anatomies. And in these cases, we did retrograde approach. We did flexible ureteroscopy with very good results in 1 or 2 procedures. But of course, that in this case of complex cases, the key is the use of a urethral access sheet. Look at this lady, 68 years old, with all that comorbidities. Look at the BMI. It's a very complex case in a very complex patients. And we decide to perform a flex approach. It was a soft stone, so the results were pretty good in 2 procedures. But the key, as I mentioned, in this kind of complex cases is to use a urethral access sheet. But Bhaskar will talk you later about suction. But as we can see here, when we are using smaller scope, we're going to have better flow. And as Etienne mentioned, better flow means less temperature and less pressure. So that's very simple, because the distance between the scope and the inner part of the urethral access sheet is bigger. So using a small scope, we're going to have better flow, less temperature, and less pressure. This is a very nice paper saying that the minimal distance between the scope and the inner part should be 1.5 French in order to have less pressure and in order to have less temperature. And this is a beautiful paper from the group of Monga when Manoj was at the Cleveland Clinic. And you can see here the diameter of a normal ureter in the proximal ureter. You can see that the diameter is between 3 and 4 millimeters. And what we should keep in mind that, well, because when they try to put a 10 and 12, 14 urethral access sheet, you can see that if the ureter diameter is less than 3 millimeters, the chance of having a urethral lesion is very high. And most importantly, the degree of the lesion is high. So please keep in mind that if the ureter is less than 3 millimeters, it means 9 French, the chance of having damage of the ureter during the insertion of the urethral access sheet 12, 14, it's very high. So all of us would like to avoid this kind of complications. These complications are related with time, with pressure, and with temperature. So if we are using a smaller scope, we have less lesions. And if you are using a urethral access sheet and a smaller scope, we have less pressure, less temperature, because we have a better flow. So in conclusion, are smaller scope the future? Yes, yes, of course, because we can access easily into the kidney and we're going to have less urethral injuries. And of course, we have better flow. Better flow, remember, means low pressure and low temperature. Thank you very much.
Thank you very much, Pablo. You have convinced us to use smaller scopes now. What is next? I think the next would be to try and have smaller scopes and to have suction in them. And so you have made my job very easy by introducing smaller scopes, and Amelia has made my job easy by introducing the ability to suck. So with that, I'm going to start my presentation, and I'll share my screen about the role of suction ureteroscopes, and is that going to be the future? I'll share my experience with this, and I think the future is here. How we harvest and how we get to this in a much better way is to be seen. But I think absolutely this is the future. These are my relevant conflicts, and I'd like to thank Vineet Gaur for some of the slides. I think these are all the innovations that we know about, training, burst wave, laser, but I will today talk about the ability of suction, which I think is probably the most important factor amongst all of these factors. So we have already heard about temperature, and temperature will cause damage and stenosis. We've already heard about pressure and high pressure. Here you can see more than 81 millimeters of mercury. There was 5% risk of urosepsis, whereas with lesser pressures, there's less risk of urosepsis. So we agree that the risk of sepsis and risk of high temperature, and I know that Etienne did mention that probably temperature is not going to change so much. I think it will change a little. So we have just looked at the features of endourology via suction through ULIS, and I'm very grateful to all the collaborators, both looking at suction scope as well as suction sheath. So what is the importance here? Well, there's better intrarenal pressure control, because with suction, the pressure is not high all the time. You have better temperature control, because you are sucking out, when the temperature goes up, you are sucking out some of this fluid and new inflow is coming in. So the temperature logically would be reduced. You have better visualization, as we have already seen. When you have debris and when you have lots of material, you can suck it out, so you get better view. Also, when you fragmenting, you have snow globe effect, and that fine dust will suck out. You will push procedure limits, and I'll show you some videos how we have pushed procedure limits. I'm not saying everybody needs to do it, but I'm just saying that with suction, you probably would be quicker, and you might be able to take more challenging cases, which otherwise you might have thought of PCNL. You will reduce operative time for sure. And with that, you would also reduce complications. What are these complications? It could be bleeding related, but more importantly, infection and sepsis related. Because again, your pressure is lower, and logically, I've just shown you high pressure would lead to more risk of sepsis, so low pressure will lead to low risk of infection and sepsis. And overall, because you can see better, you've got better flow, you'll have better stone-free rate. I'm going to share with you some of the other advantages. Pablo has already nicely covered about the small scope, and you have less pre-stenting, more primary ureteroscopy, less stenting afterwards, and they are readily available. And of course, with the 7.5 French, and I think there will be scopes which will probably get even minimally more invasive and slightly more smaller. You have better flow in terms of use via the access sheet, and you can use smaller size access sheet. So it's all an advantage when we talk about minimally invasive ureteroscopy. So, and do you need to have these scopes? You probably don't need to have it for all the cases, but for large lower pole stones or large renal stones, patients with diversion or sepsis, of course, a smaller scope, and even better, a smaller suction scope would be the need of the hour, because that is what is going to help with outcomes. here we have the suction Pusen scope. Again, similar to the cystoscope, you've got a irrigating port, you've got a laser port, and then you've got the suction button, which is in addition to the deflection mechanism. So that's a deflection, you have the suction button. So as you push the button, through this added contraception, you can suck out the fluid. Now, what is the main advantage then? Apart from everything else of a smaller scope, you have an integrated suction system, which means you can suck out the fluid as and when you need. And that, I think, is a big advantage for any case, not just difficult case. So here you can see the suction in action, which Amelia has also nicely showed. You can see you press it, you get the suction. And the irrigation doesn't need to be stopped. You can carry the irrigation. It just it reverses, the channel reverses when you're pressing it. So rather than irrigating, it sucks out. And I think there's a bit of negative pressure, and you can collect, I wouldn't say you can collect fragments, but you can collect fine dust and probably tiny fragments. You can suck it out, enough for stone analysis. Now I'll show you some cases. So this is first case of a 2.1 centimeter stone with recurrent urinary infections. And the idea is to try and fragment and suck the debris, and also to keep the pressure low because it was recurrent infections, to lower the operative time and intrarenal pressure. And this is a real life case. It is one of the first cases I did. You can see here, there's no snow globe effect, but because the suction is being used intermittently, and you don't have to use it continuously, because that will collapse the system. You're using it intermittently, but you can see very nicely the debris is getting cleared up. And because the debris is getting cleared up, you can keep going for longer. Because you're sucking out, you're not worried about temperature or pressure, or you're less worried, let's say, about temperature and pressure, because you're constantly irrigating, but also sucking intermittently. So I think that allows us to push the boundaries in such a stone. And we could do this particular case in 32, 33 minutes, something like that, which normally I would have expected to be a lot longer. You do have to be careful that you're not over-sucking, because then the system will collapse and you can get into trouble. Here I've just relocated the stones into the upper pool, and now I go into pop dusting mode with the laser, and you can see I'm intermittently sucking. What it also does is the stone fragments come closer to you when you're sucking. Because you're sucking, the fragments are coming closer to the laser fiber, so you can do a better job. And I think this is the future. So smaller scopes, of course, but smaller scopes with suction, even better. And at the end, you can see it's all dust and small particles. And you will see when I'm coming out, it doesn't suck out the fragments, but it does suck out the small particles that are attached on the mucosa. The view is excellent. Of course, it's a digital view. When you come out, you will see that these tiny little fragments attached on the wall are getting sucked out. And I think that is the beauty of using the suction scope, that you get better view. You've got you can see here now the debris is all getting sucked out towards the scope. So overall, I think this is really here to stay. There is no question about that in my mind. Let's go to the next case. So this was a patient with previous ureteric stenosis, previous balloon dilatation, young patient with smaller stone in the lower pole. So there were challenges to overcome the structure, do an endopalatomy, and then to try and use a suction scope with that. So here you are. You can see it's a very, very tight ureter. I do an endopalatomy first, and again, I'm using the suction scope. The setting I'm using here is 1 joule and 10 hertz, just to try and make a contained cut to give me enough access. Now, you can use a bigger scope, but if a smaller scope does the job, you really need to use a bigger scope. So here I have managed to get through. Then you can see a lot of debris in the kidney. And what Amelia showed, exactly the same thing. You can suck out all the debris. You don't have to aspirate using syringe. You can just do it through the scope itself, which is much more convenient and much quicker. Once you do that, you can see the stone in the lower pole, and then I try and fragment the stone. And again, I'm using intermittent suction as I'm fragmenting, which allows the snow globe effect to be minimized, because you can see the suctioning allows the stone to come towards you, and also the minimizes the snow globe effect, or that dust particles obscuring the vision. So you can see in both these cases, my first impression, I think it's excellent. It gives a good vision. It improves the debris. I wouldn't say it will suck out fragments or large fragments anyway, but for tiny fragments and debris, it is good, and it will reduce the operative time. Now, looking at the sheath suction, this is a sheath suction I'm using, using a small Pusen scope, but a suction access sheath. This was a case which originally we wanted to do PCNL. It was an encrusted stent with a large stone on the top. And we managed to break the stone, but there was a lot of debris, and normally it was too much to remove by any other method. But because of suction, we were able to come out, and you will see the scope. As we come out, all of these particles are just coming out with suction. Normally, for something like this, I wouldn't be very happy, and I might have preferred a PCNL because all this debris otherwise stay in the kidney, but not anymore, because you can actually bring out all the debris via the sheath outside, as you can see. And you can keep doing it, and you can see all the debris coming out. You have to be careful about not using a lot of suction, and that manipulation and that sort of compromise you will learn with time as you use. This is another case of sheath suction. You can see a 2 centimeter longitudinal lower pole stone, and we use the sheath suction again with the 10-12 sheath and a Pusen 7.5 French single use. I think the 3 French difference works very well, and we use a TFL laser for this case. You can see again, you can actually direct the actual access sheet to the stone, and once you've managed to break the stone, you will see this is a slightly harder stone, not like the other stones I showed, but you will see again at the end how those fragments come out nicely via the suction sheet. Why 10-12? This patient was not pre-stented. They went home the same day, and I was able to use the small 7.5 scope. The scope itself didn't have suction. The sheath has a suction in this case, and you will see the fragments coming out nicely. And I think this is the beauty of it. What would historically would have been a mini PCNL or a standard PCNL, now you can do it in a very nice way, and you can see how the fragments are coming out. And these are hard fragments. You can see they're coming out. You come to the health, go back again, and keep doing it. We did the CT scan after 24 hours. In fact, this is one of the patients we contributed to the large fan study that Vineet is doing, and the patient was stone-free on the CT scan the following day. But you can see how nicely the fragments come out with suction, which normally you have to go and keep basketing. It will take much longer, and you may not be able to take out everything. So this is another case of a pediatric patient where we planned a PCNL for this patient, but in the end, we didn't do a PCNL, and we actually managed to do it through ureteroscopy. You'll see the ureter is very, very tortuous. Again, we use a 7.5 French scope and a 10-12 sheath. In the interest of time, I'll just move it forward. You can see it's a large stone in the kidney. And towards the end, similar to before, you can suck out all the debris. So in this particular case, in the pediatric patients, as opposed to doing a PCNL, we managed to do it through a suction ureteral access sheath. I'm not suggesting it'll happen in all cases. I'm not recommending it. I'm just saying it does give you an alternate in some patients to push that boundary. But you have to judge that within your own ability and what you can and can't do. And at the end, you will see even these large, fluffy, fragmenty bits. If you want, you can basket it, but these will all come out nicely. You have to sometimes manipulate a little bit. The sheath has to be end on this, stones or whatever you have, and it will come out. So what is the evidence? It's all well and good seeing nice videos. Is there an evidence? So we published this direct in-scope suction technique, and you can see how the dust comes out, and you can have them for analysis. And this is through the scope. So what is the advantage? I think the scope channel can be used nicely. You can get to low pole in a difficult system, and you have dust for analysis. But remember, it's only fine dust, very small fragments that you can get. It sometimes, in some cases, you might have an OR time which is increased. I didn't find it, but for 2 centimeter up to 2 centimeter low pull stone, no pre-stenting, and this is the case I showed. You don't have to use a sheet with the small scopes, and you do have a small residual fragment depending on how you define it. If you define it as 2 millimeter, because remember with the scope you can only take out fragments of certain size. So going forward, what about what is next? This was a study which is completed recently with the in-scope suction. that Vineet coordinated, and we've contributed to it. And actually, there was 0 sepsis with excellent stone-free rate within 24 hours. So I think this is the future, really, with the scope suction. And of course, I think we have already looked at the differences, and innovations in suction will change the future of endourology, which is what we're discussing today. What is the evidence? There's higher stone-free rate, lower infection complication. There are lots of papers, and increasingly there are more and more publications on this, and it's much more efficient. Here you can see on the top, there's a video that shows how the sheath suction works, and you can see the sheath can be manipulated to the stone rather than the stone having to be relocated. And you can just go in and you can pick out the stones. And it is brilliant. And in fact, in this particular study, there were no infections, no accessories were used. So you might even save on the cost when you're using these sheets of baskets. Although for bigger stones, I still use the baskets, but in some cases, of course, you can avoid them. This is the latest study, and there are different types of suctions. And I think the interest is growing, and increasingly, you will be left out if you were not using it. And I think the reason you'd be left out is the stone-free rate. If you forget about everything else, the complications, etc., the stone-free rate is definitely much better using any form of sheath device. And if you talk about complications, and if you talk about procedural time, that is much better when you use either a scope suction or the sheath suction. The advantage with the scope suction is because it's a small scope, you don't need pre-stenting. You can just go in and it will work in most cases. With the sheath suction, usually you might have to have a pre-stenting, but again, not in all cases. So is suction a game changer? Well, I think it is a game changer, and let's see what the definitions are. 0 fragments, preferably no intervention, minimal complications, shorten procedural time, improve quality of life. This is a slide that Vineet has done, and I agree with him completely that actually suction is a game changer when it comes to retrograde intraanal surgery, but probably also, with Amelia has shown, and what Pablo have shown, it is not just for RIRS. With the cystoscopy, you can also do procedures in the bladder with the suction, and a nephroscopy post-PCNL with the suction. So I think suction will be a game changer in all aspects of endourology, not just for ureteroscopy, but the biggest benefit, I think, would be in ureteroscopy, and perhaps without using the baskets, etc., you might even make it more cost effective. So the advances in ureteroscopy are here for us to embrace. And once again, I think suction will be the future in terms of outcomes. Thank you once again. And I think with that, I'm going to close my presentation, and we'll be ready to take any questions. Please, if you have any questions, I think I can see one in the Q&A with Selma. Selma has asked, what is the difference between Pusen 7.5 with suction and probably she wants to say without suction. The scope is very similar. The suction and the non-suction scope, at least I can talk about the one I've used from Pusen. I've used other companies for the non-suction, but not for suction. So they're very similar. The design of the handle actually with the suction scope, I think, is more ergonomic personally. And the button is very, very intuitive. You can just press it. So the question is, would you always use a suction scope because they are same size? The answer to that probably will be, if the cost is the same, why not? If I had the option of having a suction, I would always prefer to have a suction. It's like having a cruise control in the car. You don't have to use it, but if it's there, you can use it because it allows you a little bit better journey and you're more relaxed. So it's the same thing. If do you have to have it in every case? No, you don't have to have it, but having it is a bonus. I don't know what you think, Pablo and Amelia.
Yeah, Bhaskar, I have a question about your lecture. If you are using a scope with suction, do you need the TFL to have a tiny and powder?
Absolutely not. Absolutely not. I know some surgeons, I mean, in fact, in our center, all the videos you have seen, except one, used a high-powered or a medium-powered chromium laser. And the reason I say that is a misconception that you need to have finer dust. You don't. With the sheath, depending on the size, I personally, or between me and Amelia, we like to use 10, 12, 11, 13. We usually don't go beyond that. even the fragments, 2-3 millimeter fragments will come out easily. So that is a myth. You don't need, for any suction device, any laser within reasonable use, within reasonable surgical expertise would work perfectly.
Thank you.
Yeah, Bhaskar, I agree in what you said about why not using a scope with suctioner all the time, because at the end of the day, you can use suction if you need. You don't have to use it necessarily, but when you need it, you don't know it from before. So most of the time, the CT scan doesn't show you if there are debris or if an stent is encrusted. Sometimes you don't know because you don't necessarily scan a patient from before. So when you go in and you've already opened a scope without suction, then it's going to be a shame or a sort of a waste of resources to open another one just because you need suction. So using from the beginning one with suction, I think gives you a more extra, more environment, yes, to be able to resolve many problems that could be, like the video I showed, that the calyx is completely obstructed by debris and you don't even see the stone.
Yeah. And one thing I would also add is actually, you know, with the suction of any description, whether it's sheath or scope suction, having that, sometimes you're surprised that the amount of debris in the fragments that come out, which you would normally leave in the kidney, because normally you expect the stent to do that job. So in my mind, I'm thinking, if you get a very good clearance and the procedure was uncomplicated, are we going to be in a situation in future where you put less stents? At the moment, we are not comfortable or maybe confident, or it's still new, but maybe if you get a complete good clearance, procedure is uncomplicated, you might get a situation where you leave less stents in future. Who knows? I don't know. But certainly I'll be tempted to, because I know that there is nothing. It's not like fragments that are waiting to pass. One of the questions from UV is, do you need both scope suction and sheath suction? When would you use it? So that's a very good question. I have used both. The trick is, and in my mind, and we're still learning about suction, right? So the scope suction is excellent. When you go in, you have a small scope, you don't need a sheath usually. The patient may or may not have a stent. You go in, you are doing the procedure quite quickly, you're not worried about temperature and pressure so much, and you can do bigger stones. But if you have fragments that need to be removed, I'm not talking about fine dust or fine particles. If you have larger fragments that need to be removed, then the current scopes we have with 3.6 channel will not allow that. I know that companies such as Pusen are looking at researching the bigger channels, and if that happens, then that concept will change. But currently, if you have real large 2, 3, 4 millimeter fragments, then you will need the sheath suction for that. So there are situations when I've used both, but remember, don't connect both suctions together. That's not the idea. The idea is that when you're doing the actual case, use the scope suction. Once you finish the case, when you want to remove the fragments, then you have the sheath suction. And I think that probably would be a good compromise.
Mm-hmm. And maybe in the next years, the limits will change and the boundaries will change, because, you know, most of the stones that we treat could be done under retrograde approach.
Yeah, I agree. And some people may not like it, I think. But remember, PCNL is in good hands, and we are talking about a generic PCNL versus a generic ureteroscopy. We are not talking about experts right now. In good hands with PCNL, the complications might be low, but in a generic hand, for an average endourologist, the complications may not be that low. So, and with ureteroscopy, most people can actually do, I think, a good job with minimal complications. I'm just going to read out a couple of questions. So David has said he agrees with what we have just said. Vineet has said, Pablo, great talk. Is there any way we can analyze before surgery if a ureter will allow a 10 French or a 12 French access sheath? Pablo, how do you know before surgery how would you know before surgery if the ureter would allow a 10 or a 12 French sheath?
Yeah, usually you can take the diameter in the proximal ureter in the non-contrast CT scan. So our first step is to try to put the inner part of the urethral access sheet, it's usually 10 French. So you can see if the ureter allows to put the urethral access sheet. If that's possible, we try to put the urethral access sheet. If it's not possible, we try with the 7.5. So most of our cases, we are doing the cases with urethral access sheet because, as I show you, there are complex cases. But if we can, we try to avoid put a double J and come back. We try with the 7.5 and let what we can do.
Amelia, I mean, you can share our experience. We always do a semi-rigid. I mean, I don't know if you want to put a...
Yes, so Pablo, I think these are very good techniques, and for sure you can try with the access sheet 10 French. What we normally do before doing that, and maybe some people might not think that this is needed, but we normally do a diagnostic ureteroscopy with a semi-rigid ureteroscope that, even if it's smaller than 10 French, can allow you to see and to navigate the whole ureteric length to sort of test the compliance of the ureter before you insert the access sheet, because sometimes you can see if they are narrowing, if the ureter is not compliant, if it's very fixed, if it's very tight. And so you know already that it wouldn't fit a bigger access sheet, but maybe you can put a smaller one, like a 9.5 sometimes, and maybe you cannot use a suctioning one if the PUJ is very, very tight and difficult to navigate, so that you can also prevent to waste resources, but and damaging the ureter.
Yeah. Of course.
Sorry, please go ahead, Pablo.
No, please.
So there's a question to say, if you had a choice, would you go for suction scope or suction sheet? I think that's a very good question. So look, the way I see it, Tarek, is when you use a sheet, you always use a scope, right? So if the ureter is quite narrow, then you don't use a sheet, of course. You can use the 7.5 suction scope on its own. But if you had a big stone in the kidney, and you think you're going to use an access sheet anyway, then I would use a suction sheet, but with a suction scope. And as I said, you don't use them together. You don't have to use a suction scope in all cases, by the way, but you don't use them together. When you are operating, then the suction scope will allow less snow globe effect. You can carry on for a bit longer, as I've shown. And at the end, when you have fragments, you can take it out, because normally that's what we do, or that's what we do. We have a scope and we have a sheet. The only difference is then you have a suction scope and you have a suction sheet, but you're not using the suction together. You're using it at different times to optimize and maximize the benefit you can get out of them. But you don't have to have it, but it will be good to have it. And I guess ultimately it will come down to technology and probably more importantly, price. And that is a debate, not for today, but probably for some other time. There's another question, Amelia, if I can ask you. Do you think dual channel scopes, which is large channel for suction, would give you a more superior result for dusting? So if you have two channels, the larger for suction, I don't know.
It's interesting. I think this is just the beginning now of the suction era, let's say, because we've been waiting for suction scopes for many years. So it's amazing that now we have this scope that will allow to suction. But the working channel is just one. So it's true that many people wonder, how can it suction and irrigate at the same time? But I have to say, and I will answer this question in a second, I have to say this works despite you're still irrigating. When you push a button, you really see the suctioning in action, and you see the fragments, or sorry, the dust or the debris just clearing up your view. So whatever technological innovation was there, it was definitely effective. And I guess that with a bigger suction channel, working channel, probably would be even more effective, but you need to see if maybe the cavities will collapse too much, or even if you have to use too much pressure for the irrigation to allow adequate distension of the cavities. So I think it's more a question for the companies rather than for us. And for sure, the future will hold all these questions for us in the next few months, I'm sure.
So I'll ask something to Pablo next. Pablo, one of the downsides I find is you need to use more irrigation, right, when using suction, logically. Are there any other downsides? So you've mentioned all the nice things. In your view, is there any other downside that comes to your mind? To me, it's the only one thing I can think of is lots of irrigation is needed sometimes because you're sucking out all the time. What else do you think we need to optimize it, or is there any other downside to it?
So I think that we need to learn and we need to have clinical data, because sometimes the lab data are not great, and we saw that with TFL, So I agree with Amelia, but we need to create clinical data to answer the questions, because sometimes lab data are not enough, and of course are not useful in clinical practice. So we usually use gravity just to know how is, because we don't have in Argentina yet the way to measure the pressure inside the kidney. But with the gravity, we can turn our view and to see if it's dropping, we have still low pressure inside the system. So we take a lot of care about the pressure and a lot about the time. So I think that pressure and time are the most important topics when we are doing a retrograde procedure.
That is great. I think we'll take one last question and then we'll finish. What about bendable access sheets? So I think there's an anonymous attendee. I think what we're talking about, it's addressed to the person who's asked, is the suction sheets we're talking about are bendable access sheets. They can go to they can bypass the PUJ. Take care when you're doing it, as you would normally do, but the tip is flexible, and that's what you mean by bendable. And they can go to the calyx and they can bend nicely. And that's what we're talking about. And then once you're there, you can fragment and suck it out. Any other last comments? Amelia, starting from you. Amelia, any other last comments?
Just inspired from one of the comments that this attendee David made, because it wasn't a question. He just said, we actually tried to move the stones from the lower calyx to the upper calyx just by scope suction. And it happened to me that when you have stones that are very difficult to reach or in a very steep angle, lower calyx, and you can't get there. Sometimes with the suction, because it reduces the volume of the distension of the calyx, the stones get closer to you. So I think this is another probably improvement or another good point of the suction scopes of when the basket or the scope have limitation, maybe the suction can fill that gap. So that's one other comment.
Bring the stone closer to you, sort of. In a way.
Exactly.
Yeah. Pablo, any other last comments from you?
Yeah, thank you. So my last comment is to take care about the ureteral wall, to take care about the diameter and the temperature, as Etienne mentioned. We are seeing more and more strictures and are maybe related with temperature and with size. So take care about that. And sometimes it's better to put a double J and perform a pre-stenting procedure for hard or bigger stones.
Great. Thank you so much. So I will say thanks to Manuel, thanks to Wendy, thanks to Pusen. And I know there are lots of listeners all over the world, in South America, in Europe, in China. I'm really grateful to Pusen and to all our listeners and to all the questions that have come through, and looking forward to the next one, which probably will be in month of May. So again, thank you once again, Amelia, Pablo, Etienne, who couldn't be here, and to the whole team. It's been a pleasure.
Thank you very much.
Thank you. Have a good day.
Yeah. Well, thank you all for listening today. Special thanks to our course director, Professor Somani. Thank you, Dr. Contreras, Dr. Pietro, Paolo, for such insightful and instructive, useful presentation. Thanks also to the Chinese Tencent platform, where we're having hundreds of attendees. Apologies for a few automatic Chinese subtitles that are not 100% correct. Well, I think now it's time to say goodbye. One more time, thanks again for joining today. Stay tuned. I wish you a very good day. Take care.
Bye-bye.
Bye.
Thank you. Bye-bye.